Mental Health Masterclass Risk and Distress Education. Risk, challenge, distress and safety are words which are often discussed in our local schools. Questions on how to support young people with complex mental health concerns are becoming more and more common. It can be difficult for schools to know what to do when faced with complex mental health concerns. The good news is, however, schools present a safe and central setting for promotion of psychological and social well-being for early mental health interventions. Understanding what distress is and how it may look in a school context. We first would want to define distress. It is extreme anxiety, sorrow, or pain. It is a state of being which is overwhelming and upsetting for the individual and others around them. Distress may look different depending on the individual. Distress can sometimes be evidenced by crying, yelling, pacing, running away, quietness, lack of emotion, and even silence. Some further behaviours include difficulty with self-image, changes within moods, engagement in non-suicidal self-injury, challenges managing emotions, ongoing self-criticism, or negative self-talk, drug and alcohol use and misuse, isolating from family and friends, engagement in risk-taking behaviours, rumination of suicide and death, inability to maintain concentration, and often a noticeable change appearing irritable. What is important is you recognise the distress the individual is feeling and work with them when highly distressed. Focusing on exploring factors which lead to distress. Often circumstances we experience in life cause us to feel these strong and intense feelings. It could be a trauma from our family of origin, a relational fracture, the loss of a loved one, feelings of guilt or shame. It may be hard to discern what the cause of the distress is, but all of us at some stage in our life will experience this kind of feeling. Distress is the response we see when a person is hurting. There also may be a number of concerns which has led to the individual to feeling distressed. The child or young person over a long period of time may have experienced trauma, hurt, difficulty within relationships, and they feel as though they are unable to manage these stresses any longer. As people who are supportive and want to support young people, part of our role is to encourage them to build up their resilience and ability to manage their distress. Often encouraging young people to sit with their distress or allowing the feelings to be there without pushing them away will assist the young person to build this internal resilience. Developing a deeper understanding of distress, suicidality, and non-suicidal self-injury in young people. When children and young people express distress, often it's in the context of suicidal behaviour, suicidal ideation, or non-suicidal self-injury. Suicidal behaviour is any action that could cause a person to die, such as taking an overdose on medication or crashing a car on purpose. The term suicidal ideation refers to thoughts that life isn't worth living, ranging in intensity from fleeting thoughts through to concrete, well-thought-out plans for ending one's life oneself, or a complete preoccupation with death and destruction of self. Thoughts to end one's life are common for young people, especially those who may be experiencing high levels of stress, anxiety, or ongoing complexity and trauma. When exploring further with students in relation to their suicidal ideation, looking at one's risk factors, both static and dynamic risks, can be helpful to determine ongoing distress. Individual risk factors for suicide ideation and suicidal behaviour include previous history of suicide attempts, history of substance use and misuse, diagnosis of previous mental health conditions including depression, anxiety, relationship fracturing and ongoing conflicts with parents, partner and peers, legal or police matters, access to means to end one's life, recent death of a loved one, family or friend, ongoing bullying, losing a friend or family member to suicide, complex physical health concerns, illness or disability. Static risk or risk that is unchangeable includes age, gender, family history of mental illness and vulnerabilities, previous attempts to end one's life, previous trauma, and a history of family death by suicide. Dynamic risk or risk that does change includes current crisis, lack of support for the individual, drug and alcohol use, current mental health symptoms, and access to means. When supporting students, these challenges are important to consider in order to determine next steps of support. The definition of non-suicidal self-injury is the direct, deliberate, self-inflicted destruction of one's body tissue in the absence of suicidal intent. Most common types of non-suicidal self-injury include cutting, scratching, and burning. However, some behaviours include pulling at hair, punching self or objects, pinching, biting, ingesting poisons, overdose of medication or drugs, some risk-taking behaviours. Often, non-suicidal self-injury is done in discrete areas. Most common areas are arms, legs, and hips, but not limited to these areas. We want to validate and support young people who engage in non-suicidal self-injury. How we speak to students about behaviours has great importance. Language such as self-harmer or cutter or attention-seeking are not examples of strength-based language. Language like this is not helpful and does not validate or support the young person. In fact, quite often it disregards the complexity of the distress and challenges the child or young person is experiencing. Non-suicidal self-injury can be a risk factor for suicide. However, we need to remember the definition. Involves the direct, deliberate, self-inflicted destruction of one's body tissue in the absence of suicidal intent. Not all people who engage in non-suicidal self-injury will experience suicidal ideation. Risk factors for engagement in non-suicidal self-injury includes family history, recent loss, persistent bullying, complex family background, isolation with peers, trauma. Often young people will engage in this behaviour as a release from strong emotions and feelings and an attempt to control and manage difficult feelings and to connect with others. A number of studies have suggested engaging in self-harm behaviours releases endorphins, which provides a temporary relief. What also needs to be noted is that often if one engages in self-harm, that person may have ongoing feelings of shame and guilt, which can lead to further engagement in self-harm. Understanding the importance of mental health assessments within a school context and how to gather the most appropriate information. In order to determine next steps, you as the educator will need to assess the individual's current concerns. A mental health risk assessment is a direct conversation with the student about their suicidal thoughts, plans, and intent. This conversation with a child and adolescent should be empathetic, allowing the student to discuss the cause of the distress, the possible triggers, and suicide openly. A mental health risk assessment should include current risk of harm. What are the thoughts they are currently having? Strength of the young person or child? Protective factors of the young person or child? Who are the people in their life they trust and feel connected to? Are they able to identify people who support them when they are feeling distressed? By exploring these areas with the individual, it will give you, the adult, a deeper understanding of the distress the child or young person is experiencing. When completing this risk assessment within a school-based context, your role is not to determine whether this young person will take their own life or not, nor to determine whether they will engage with suicidal behaviour in the future. The aim of a school-based risk assessment is to identify what interventions are needed for the child and young person right now to support them in their distress, to determine what resources are available to you as a school, and what protective factors can the child or young person identify even in their state of distress. Completing school safety support plans for students expressing complex distress. When returning students to school after experiencing distress or a critical incident, often planning their return can be of great help. Whilst distress may look different depending on the young person, having a deeper understanding of the student's triggers and responses will assist you to support the student when these feelings return. When speaking with the child and young person in planning their support and safety plan for school, use direct questions to ask the student and their family of what supports may be of benefit for them. Ask the young person to list actions, plan and goals to help with this mental health and well-being at school. Ask them to identify who they can talk to at school when they feel unsafe. By doing this, you're encouraging them to develop help-seeking behaviours. Agree on a number of contacts with the young person to check on their health, safety, and well-being, such as twice weekly. Review the plan regularly. Often, supports and strategies to assist when feeling distressed will change, and ensuring the plan is reviewed will enable you as the school teacher to be as confident as you can in relation to supporting the student. If you as the teacher or support person are struggling to manage your own anxiety and concern when supporting a student with mental health complexity, it can be really helpful to remember these few points. Acknowledge you feel anxious. It's a normal response to a challenging situation. Reminding yourself that this is difficult is important. Continue to breathe. Take time to take a few deep breaths, as this will assist you in continuing to think through the current concern to the best of your ability. If you are unsure about an answer or what to do, just give yourself a minute. If the young person is with you and alert, you will have time to think through what you feel is necessary to do. Know your school's process of managing acute mental health concerns. Share with someone your concern. You don't have to manage it alone, nor are you expected to. Obtain support for yourself if you feel as though you are struggling to support children and young people with ongoing trauma and distress. At times, our own vulnerabilities can be impacted by the support we provide, and you may need ongoing care and supervision to maintain your own health and well-being. Case study Risk and Distress. Case study 1, Mental Health. Jade is a 15-year-old female who has recently been discharged from an overnight stay in hospital. Jade was sent to the ED from school after expressing suicidal ideation while at school in the context of fracturing peer relationships. She reported that she's been bullied online by her friends because she did something silly at a party 2 weeks ago, and she no longer feels as though she can go on. Jade has a long history of engagement in non-suicidal self-injury on her arms, and on her most recent discussion with you, she shared she has started cutting on her thighs. The head teacher wellbeing and school counsellor are aware that Jade has experienced family violence, and she reported she was assaulted by a male student at a party 18 months ago. This event was investigated. However, Jade at the time declined to press charges. Upon her return to school, Jade has expressed to the head teacher wellbeing she still has thoughts to end her life. However, she does not have a current plan or intent. She doesn't want to go to class as her old friends are in that class. Case study questions. What changes in behaviour have you noted? Prior to hospital admission, you were aware of previous engagement with non-suicidal self-injury and suicidal ideation. What mental health symptoms is Jade displaying? Disclosure of suicidal ideation at school in the context of relational distress. Engagement in non-suicidal self-injury. What are your next steps from a school perspective? Discussion with Jade around managing her distress in the context of attending class. Ongoing support and discussion of how to support her at school. What steps are needed to be put into place when she feels distressed? Does she need a time out card or time within the welfare hub? What further information would you need to obtain? Support provided for Jade upon her return to school. Consider what is needed for the school to feel comfortable and confident to support Jade at school. Possible return to school planning meeting with both school and outside support agencies for Jade. What referrals pathways would you consider? Community mental health team follow-up from Acute Adolescent Mental Health Service. Case study 2, Intellectual Disability and Mental Health. Lockie is a 12-year-old male with an intellectual disability who attends a local mainstream class. From kinder to year 2, Lockie exhibited behaviours of calling out in class, not following instructions, and speaking back to the teacher. However, each year teacher was able to manage and redirect his behaviours. In year 3, when Lockie was expected to participate in further learning, his teacher noticed he was not able to complete the work and his behaviour heightened, which included calling out, not following instructions, kicking and throwing furniture and books at both the teacher and students. Due to these behaviours, Lockie was presented to the learning support team for a cognitive assessment and completing questionnaires for mental health. As a result of these tests, Lockie was diagnosed with an intellectual delay, oppositional defiance disorder, and attention deficit hyperactive disorder. Now in Year 6, Lockie has been noticed to become agitated in class when he is asked to complete work. He becomes distressed and angry, and often leaves the classroom in a huff. More recently, Lockie has been saying to his teacher, "I might as well not be here, and I'd rather be dead." When Lockie has expressed his distress, his dad Jones has been called to come and pick him up from school. Lockie and his father live locally. Dad does not work due to a workplace injury he sustained 8 years ago when Lockie was a toddler. Dad is supportive of the school but struggles himself to follow through with referral pathways and has shared with the teacher before, "I just give him the iPad when at home." Mum is remarried and lives in Sydney and has no contact with Jones or Lockie. Today, Lockie left the classroom in a huff after being asked to complete a maths worksheet. He went to the second story of the school classrooms and attempted to climb on the railing, shouting, "I don't want to be here," and "I told you I'd be better off dead." When the deputy principal attempted to speak to Lockie, Lockie ignored him and shouted, "You don't understand," and attempted again to climb the railing. Lockie was crying and breathing loudly whilst holding onto the railing. When asked to let go, he shouted, "You'd like that, wouldn't you?" On this day, the Student Learning Support Officer, Mark, who Lockie likes, is off sick, and Lockie keeps asking for him to come to help him. Case study questions. What changes in behaviour have you noted? Difficulty with classwork, leaving the classroom distressed and climbing on the railing outside the classroom. What mental health symptoms is Lockie displaying? Distress, threats to harm self, physical responses, heavy breathing and crying. What are your next steps from a school perspective? Safety for Lockie on second story classrooms, ongoing support for Lockie in class for academic work. What further information would you need to obtain? Conversation with Lockie in relation to distress and possible triggers when he feels overwhelmed. Consider what is needed for the school to feel comfortable and confident to support Lockie at school. Possible return to school planning meeting with both school and outside support agencies for Lockie. What referrals, pathways would you consider? Support for his father in managing Lockie's behaviours and an NDIS referral.